pancreas and spleen today. We're going to do it all. All right, here's the objectives and what we're going to talk about today. We'll talk about acute conditions and the more malignant conditions that do with the pancreas. All right, so it's important to understand the anatomy, and we've kind of already covered some of it, but what's important to understand about the pancreas is basically, we already talked about the gallbladder and the common bile duct and how they kind of share that little channel there, but it's important to understand where the pancreas lies in the retroperitoneum and its relationship to so many other structures in there, which is why it can create a lot of problems for us when they get sick, especially with like our acute and chronic pancreatitis. So you can see in, like they got the CT and those images up there. Basically, it just shows, like I was saying, where it lies within the belly and why it causes so many problems when we have malignant conditions with it. It's another reason why pancreatic cancer can be, it's so fast when they get it and malignant because it's so close to all these other structures, and it's very invasive, and typically we don't catch it in time because it's symptomatic, and we'll talk about that later, but because of its relationship to all these other structures, this is why, and we'll talk about it in there, why we get like colon sign and Gray Turner, and some of those other findings we might see on exam. But since the CBD goes through it, through a small portion of the pancreas, and it shares that, is a lot of times why they get jaundice as well, especially with like pancreatic cancer can sometimes be their only presenting symptom. All right, so where does it sit? It's, it's a retroperitoneal organ, and when it gets inflamed, it can rapidly spread to every direction. So that's why, patients that usually have acute pancreatitis are usually pretty sick. And we'll talk about those. You don't need to, memorize this, but you do need to understand the pancreas has an endocrine and an exocrine function. And obviously the endocrine function, insulin plays a huge role in that, and that's something that we can measure, especially with like our hemoglobin A1C. And then we also have our exocrine pancreas, which is what creates all our digestive enzymes, the pancreatic fluid, electrolytes. So it's just important to understand its two roles, and what, based on the physiology of those, what findings we may see when the pancreas gets inflamed, or when we get cancer, or when we get some trauma to it as well, which we'll talk about a little bit in this block, but mostly in block 3 when we talk about trauma. So what is the common thing we see with it? And that's going to be acute pancreatitis. So it doesn't, we do see it quite frequently. Typically it's associated with some sort of biliary obstruction or alcohol. This is why we like to, whenever we suspect it's a pancreatitis, we like to rule out that there isn't any gallstones there, so an ultrasound is a great test for that. We also might see some LFT abnormalities. We'll talk about the labs we use for this, but it does have a pretty high mortality rate, so especially if they get like necrosis with it, they'll be significantly fluid down when the pancreas gets inflamed. And here are some of our here are the most common causes. Obviously, alcohol and gallstones are the most common, but there's all kinds of other things that can cause an acute pancreatitis. We always say scorpion venom. That's like super rare. Like, it's rarely ever seen, but it can cause it. So whenever like in the hospital and you're faced to when they're pimping people, everybody always says scorpion, which is funny. When really it's alcohol and gallstones are the most common causes. But as you can see, like it has been associated with like certain like cardiopulmonary bypass. There's all sorts of other infections that can cause it as well. Not as commonly though, especially in our society, it's typically alcohol and gallstones. And this isn't something you guys need to memorize, but it's something to understand just the pathophysiology of pancreatitis. And so we have an early and a late phase, and then typically, when it's in the milder form, we call it edematous pancreatitis. And what we worry about is necrotizing pancreatitis, which has a pretty high mortality rate. So those are the ones we always watch out for, and that's really what we're looking for when we're evaluating these patients. All right, so what does acute pancreatitis look like? It's typically you know, the unfortunate thing is it's like every other belly pain. That's what makes belly pain so difficult, and that's why we typically cast a pretty broad net when we're evaluating this. But they normally have like significant nausea and vomiting, they're PO intolerant, and they have a mid-epigastric boring pain that they sometimes describe it as, and it radiates to the back. It can also go to the chest, flanks. You can see like a pretty wide presentation with it, and they usually have a fever as well. They're usually really sick when they have a pancreatitis, but the most common presenting symptom is that abdominal pain and that nausea and vomiting. So, as you guys can imagine, they're going to be pretty significantly fluid down when they present. So our overall goal is going to be resuscitation on these patients first. All right, there's like your colon's a great Turner sign. These are very rare, not commonly seen, but because of the relationship of the pancreas and the belly, this is why you see these findings. Like you can see the colon sign if blood tracks down the balsiform ligament, and you can see that, and then you'll see those flank findings as well, but not very commonly. I think I've seen gray Turners maybe once. I've never seen a colon sign in anybody. But the important thing on your exam is evaluating their fluid status. So obviously blood pressure is a great, is one of the indicators we can use. Are they tachycardic? Basically, are they stable or unstable? And then you need to evaluate like their mucous membranes. Are they dry? Are their eyes sunken? They may have some scleral icterus. And then typically they'll have a pretty tender abdomen, especially in the mid-epigastric region. And then on auscultation, you may find decreased bowel sounds or hypoactive bowel sounds because they have an ileus with this. And then, like I said in the palpation, it can be diffusely tender. They might have rigidity. Typically, it's mid-epigastric, but it's sometimes hard to differentiate in these patients, which is why abdominal pain can be difficult and why we typically get the lipase in every abdominal pain patient, especially when they're PO intolerant. With the nausea and vomiting, we always want to get a lipase just to voice out. All right, so what do we do for these guys? How do we diagnose this? So obviously, like I said, first we need to resuscitate them. Sometimes they require like 3 to 6 liters, so that's going to be our first priority, is stabilizing them. And this all usually happens at the same time. So when they present, we'll typically get 2 IVs, we'll draw blood. While our blood is cooking, we're resuscitating them, we're getting them fluids. And then what do we see on the lab? So, on our CBC, some things we can see, like they can be hemoconcentrated, so you might have an increased hematocrit from the dehydration. So that's very common. The U8 might have an increased spectrograph, which can be another sign of dehydration. And then they could have the elevated BUN, which can be like a prerenal sign of dehydration as well. So you look at your BUN to creatinine ratio, and if it's over 20 to 1, you can sometimes look at that. They may be hyper or hypoglycemic. Obviously, a lot of these patients will have some sort of underlying comorbidity. Especially alcoholism, but some of them may be like pre-diabetic, so you can see a hyperglycemia with these in some patients. And then if they've had prolonged nausea and vomiting or PO intolerance, then you may see a hypokalemia. If their billy is elevated, then you need to think about a stone, which is why an ultrasound is a helpful test for this. And then we get our liver functions test. CRP is, it's a non-specific test, but it is really good for pancreatitis, and it's typically significantly elevated. Like 150 is pretty high for a CRP, but that's something you can see in pancreatitis as well. But the gold standard is our pancreatic enzyme, so amylase and lipase. Lipase is the better study just because amylase can be cleared relatively quickly. So lipase above 3 times the normal limit is typically our most accurate test and the gold standard we use now for diagnosing pancreatitis. And like I said, if you suspect any sort of cholelithiasis or cholelithiasis, you need to get that ultrasound. You can do that at the bedside, simple, easy, fast. But the CT is the most accurate test we use. And that'll just give us the extent of the pancreatitis. And we always got to worry about other complications with it, like necrosis, abscesses, pseudocysts. So we always want to get a CT on these ones. If you're if they're inpatient, you can get an MRI quickly, that might be an option. But typically we don't go for an MRI on these patients. The CT is the best test we have. All right. So to diagnose this, you need 2 of these 3. So it's going to be your, that abdominal pain, typically in that mid-epigastric region that radiates to the back. You then have one of your pancreatic enzyme levels elevated. Typically lipase is what we use right now, and it's the most accurate. So that's going to be 3 times upper limit of normal, and then characteristic CT findings. So you can diagnose it without a CT scan, which we do frequently, but the CT is typically what we get to identify the extent of the pancreatitis. And then most of these are mild, so like 80% are mild, just edematous. They would usually are admitted to the hospital because of the PO intolerance and their significant hypovolemia. And we just monitor them, give them IV fluids. Sometimes if they're PO intolerant for a prolonged period, we may put an NG tube in them. And then we have all these wonderful criteria we use that can help identify like how severe the disease is, which we'll talk about. Have you guys seen these ones before? Like, I know you heard of Ranson's, right? It's not very accurate, but that's the one. That's historically that was one of the first ones we used, was our Ranson criteria. But the problem with it is that it has 11 parameters, but some of them you get like initially, and then it requires more data 48 hours later, which can make it a little bit more difficult to use this. And it doesn't have a great positive predictive value, so it's fallen out of favor recently. We have other scores like our BISAP score, which we'll talk about next. But all right, I'll give you guys a second to read this and let me know which one you guys think it is. What do you guys think? Number 1? No? All right. Yeah, basically, most of everything on there is usually opposite. We don't get our pancreatic enzymes for the Ranson score, but everything else, like your PO2 should be less than 60, not greater than 60. Obviously, the systolic blood pressure wouldn't be elevated on that, and it's over 55. So yeah, our white blood cell count is what we expect to be elevated with this. Then we'll talk about some of the other scoring criteria we use, which are a little bit better. Yep.
So for this exam, based on this question, are we going to need to know those Ranson criteria pretty thoroughly for the exam?
Or should we focus on the ones that you confirm on?
You guys should just know everything, basically. No, you guys need to have an understanding of the Ranson criteria. I'm not going to ask, we're not going to ask you which one of these criteria like it is on here, just because it's not as accurate of a score. But you do need to know, you do need to have an understanding of the criteria of what we use it for. But, I mean, most of it is, I guess maybe because I've been practicing for a while, but a lot of those scores on there, like on this question, the only one that's really abnormal is our one option on there. So even if you didn't know it, hopefully you could get to it with that, but I'm not going to ask you a question on Ranson criteria. I'm definitely going to ask you a pancreatitis question, so it's not going to be anything like that. All right, and then we have our BISAP, which is our bedside index of severity. And that looks at our BUN, so if it's greater than 25, if they're impaired in any way or an alteration of their mental status, if they have any of the SIRS criteria, if they're elderly, over 60, which some tell me that's not elderly. I think 65 is the official cutoff, but it's usually 60-year-olds that tell me that. And then the presence of pleural effusion, which is usually portends a poorer outcome if they have pleural effusion. We used to use, so we have the other scores in the bottom. I know you guys have heard of SIRS. Have you ever heard of SOFA score? Yeah, that's like, these are like sepsis scores we use sometimes in the hospital. But the CRP, which is that inflammatory marker, is going to be significantly elevated. And that's a very useful serum test we like to use to measure the severity of the illness for this one. All right, so like I said, they're going to be, fluid down, they're going to be hypovolemic, so sometimes they require a significant amount of fluids. And I feel like anything that affects the pancreas kind of does that. Anybody who's got like DKA, or if they have symptomatic hyperglycemia, a lot of times they're going to be significantly fluid down and require a lot of fluids. So we got to fill the tank up first. So blood glucose, obviously, because we have that endocrine function of the pancreas. So our glucose will typically be abnormal, so they'll usually be like hyperglycemic, and that can require some aggressive control, like some insulin therapy. And we always have to be careful when we do that, just because we could tank their glucose, their blood sugar as well, and they can become hypoglycemic. But they're going to be in significant pain, bless you, and we're going to need to give them some sort of narcotics. And like I said, not everybody gets an NG tube, but if they're PO intolerant, they have continuous nausea and vomiting, sometimes we will, just to help for symptomatic control, or if we see that bilious. And then we do worry about chemoprophylaxis for these patients, so we give them some sort of gastric anti-secretory med, which is a PPI or an H2 blocker is what we give them, and then we do have to DVT prophylax them, especially if they're going to be admitted to the hospital.
Is that treating with just aspirin, or is that?
No, it might be Lovenox or something. Yeah, typically something a little bit more than aspirin for DVT prophylaxis. But it also depends on, the acuity and how long their hospital stay is set to be, and if they're able to ambulate and everything like that. So a lot of those factors are in there. Typically, the elderly patients will get more concerned just because they're going to be bedridden when they're in the hospital, or if their mobility is already limited in the first place, it can be a little bit concerning. But we typically want to prophylax all of these. And then here, we have some algorithms on here, but typically like our mild edematous, which is 80% of them, they typically improve after fluid, resuscitation, and then PO intolerance, and then we advance their diet. They typically spend a couple days in the hospital. The goal here is to figure out what's causing this. Why did they get the pancreatitis? Now, if you have a great historian and they're like, yeah, I'm an alcoholic, I drink, however many a day, and then you usually times that by 2 or 3, depending on how much you trust them, for their alcohol intake. So I think most commonly I see it with alcoholism, but I think textbook-wise, I think gallstone might be more common. But we don't do a lot for the mild cases other than just monitor them in the hospital and conservative management. If we're worried about some sort of biliary cause, then we need to look at doing possibly a cholecystectomy and evaluate them for one of those stones. And then if it's severe, then we got to worry about like a cholangitis or an infection going on as well with it. So those patients are typically going to get an ERCP, which is diagnostic and therapeutic, and they can do a stone extraction for those. And then chronic pancreatitis. One other thing on acute pancreatitis, you guys see this in soldiers or service members, it's actually disqualifying after their second episode. So something to think about, you don't need to know it now, but something to remember. So it is something that they can be chaptered from the military for, because it can create a lot of problems. And most of the ones I've seen were from alcohol. So yeah, it was unfortunate, and they didn't want to stop drinking. But this will become important when you guys are if you're deploying or anything, some of these limiting conditions. You might have to think about chaptering versus a waiver for them. All right, chronic pancreatitis. This is typically from your alcoholics, and it's just an inflammatory disorder. They'll have glandular fibrosis, leading to that endocrine insufficiency. So, they'll typically start with their chronic alcoholism, might be pre-diabetic, moving into diabetic, and requiring therapy for it. The problem, the difficult part of this is they don't present as severe as your acute pancreatitis cases. That's why it's important to consider it when you're treating a patient for abdominal pain. But yeah, typically asymptomatic. Sometimes they'll have that mid-epigastric pain that radiates to the back. A lot of times they'll have that weight loss, steatorrhea, and just a mild abdominal pain. They're typically not PO intolerant like with acute pancreatitis. And unfortunately, there's not a lot we do for chronic pancreatitis other than try to, lifestyle modifications, which can sometimes be difficult or patients aren't compliant with. So yeah, like I was saying, it doesn't show any real pancreatic inflammation. We'll still get a CT scan on them, but we really want to look at their overall functional status. So this is where, our hemoglobin A1C is a great test we want to do just to look at the endocrine function of the pancreas, and it's the most accurate. We don't do a fecal elastase. It might be something done more on an outpatient setting if you're really worried about the exocrine function of the pancreas, but you typically have to lose 90% of your pancreatic function to start seeing that. So we don't typically order those, but it is an option. And then sometimes you can see other conditions that cause this, like hypertriglyceridemia, especially like the familial hypertriglyceridemias. You may have a pancreatitis or chronic pancreatitis secondary to that. And then some of our like neuroendocrine tumors we'll talk about. You can also have like a parathyroid, like a hypercalcemia can cause some of this. All right. So patient epigastric pain, what is most useful in differentiating the etiology of acute versus chronic? Yeah, number 4, it's going to be our pancreatic enzymes are going to be our most useful test. And a lot of places now don't, we used to do like amylase and lipase, a lot of places just do lipase now instead. And we don't run very many amylase tests. Now, one of the places I work at randomly only has amylase, which is odd. It's the only place I've ever seen like that, so sometimes you do have to use it. But typically our lipase is at most military treatment facilities is what we're using. And then the important here is we have to do some sort of diagnostic imaging. Typically a CT is indicated, so looking at the pancreatic morphology. And then more on the outpatient side, we'll do like an MRI, and we might have to refer them for the MRCP or ERCP, but since this is usually, since it's chronic and it's not an acute condition, we typically don't need to emergently order any of these. But this is what's going to help us kind of identify the morphology and any sort of ductal abnormalities we might have with the pancreas that requires any sort of surgeries, which we'll talk about next. But it's typically medical therapy, and then we just, based on our imaging, we have to decide whether it's like a large duct versus a small duct pancreatitis, and there are different procedures we can use for it. We're not going to ask you which procedure for which, don't need to worry about that. But you do need to understand that there are procedures we can do, and there are times we will remove some of the pancreas. We try not to remove the whole thing. So really the only indications we have for like a total pancreatectomy are failure of our previous operation. So if you have a patient who had a pancreaticoduodenectomy and they failed that treatment, then that's maybe one of the few times we'll do a total pancreatectomy after that. And obviously if you remove the pancreas, you have a pretty difficult time controlling their diabetes. And then they'll have malabsorption as well, so they'll have quite a few complaints. And this will be like a lifelong condition that you're going to have to manage, or they'll have to manage. And this is just a graphic of the different procedures that we use. And basically, we're rewiring the whole system there. We're going to move, parts of the duodenum, we're going to attach the pancreas to different sections. And based on where the disease is in the pancreas, that's how we decide which procedure we're going to use for this. But it's not something you guys need to, memorize each procedure and why we're doing them. Just have an understanding of there are different procedures depending on where we have the diseased pancreas and what we're going to do for it. All right, so what we do need to worry about are the complications from it. So even with our acute pancreatitis, since we do commonly see it, we do have to worry about the complication. The most common one is going to be our pseudocyst. So this is going to be a patient that had an acute bout of pancreatitis, and then 4 to 6 weeks later, they present still having pain, and that's when we need to start thinking about, oh, maybe they have a pseudocyst in there, and we need to image them again and evaluate for it. And then pseudoaneurysms are less common, but it certainly can be a consequence of that severe inflammation. And once again, we'll get some CT imaging or MRI, depending on the setting and how acute we're concerned for. As you can see, they get pretty large, so that's like half the belly almost, it looks like, right there with that pseudocyst. So it is something we always need to consider, especially if they had a recent bout of pancreatitis. And then pancreatic trauma. So we'll go into a lot more depth and detail when we do our trauma block, but it is important to talk about it here. So this one, typically you'll see it on like the board questions. It'll be like a kid on a bike gets handlebar right to the epigastrium. And you need to consider that they have some sort of pancreatic trauma. It is a retroperitoneal organ, so all of those, if they get injured, it takes quite a bit of force. So you need to evaluate for every, you need to evaluate the entire patient. Typically, they'll get CT, like head, neck, abdomen, pelvis for these patients because of the amount of trauma it takes to damage it. We need to rule out, especially like lower spine fractures. Amylase, it's not a reliable indicator, but it can be elevated if they have trauma. So a lot of times we will get the amylase with the trauma patient if we suspect any sort of pancreatic injury. And that can be an indicator because even the CT test isn't a great, it's not going to, we won't have a lot of findings on it that are diagnostic for any sort of injury of the pancreas. So sometimes we'll get that inconclusive or equivocal CT scan, but in the setting of a hyperamylasemia, then we might think, okay, maybe they do have some damage to the pancreas, we need to monitor them a little bit more closely. But most are treated with supportive care. Obviously, the pancreas has an important function in the body, so we don't want to go in there and remove them if we don't have to. And then we also have to consider with trauma as well. Pseudocysts are very common after trauma too, so we need to think about that, 4 to 6 weeks after that trauma. If they're still complaining of pain or if they return to see you. And then, our two options are typically drainage versus resection, so taking a portion of the pancreas out versus just draining the pseudocysts or whatever sort of trauma that they have there. All right. All right, what do you guys think? I know you got the answer on your slides, but yeah, it's going to be 2. So any sort of like chronic pancreatitis, that's why we do the, all of that imaging with it, because we want to make sure they don't have any sort of pancreatic duct abnormality prior to surgery, because that could be a different treatment for us. Like I said, depending on where we have wherever the pathology in the pancreas is, that's going to guide which procedure we're doing. So we do need to identify this prior to any surgical treatment. And that's going to be with our CT and MRI, MRCT. Pancreatic cancer. So typically when we say pancreatic cancer, what we're talking about is ductal adenocarcinoma. It's the most common. It does have, second most common GI tract malignancy is the 4th leading cause of cancer-related mortality. The problem with this is typically the patients are asymptomatic and it's not caught till it's a later stage. So like stage 4 pancreatic cancer has a very low survival rate. I think it's like 12%, 10 or 12 right now when they catch it. And typically by that point it's already metastasized. And it's unfortunate, so we don't have very many great treatments for it. But it is very aggressive and it disseminates early. Anybody know anybody that's had pancreatic cancer? Usually it's like a death sentence. It's not good. And then here's just a breakdown. It kind of shows you, the ones we're most concerned are the ductal adenocarcinoma. They're the most common. But here it just gives you a representation of all the other ones that they can have. And this, these patients are typically going to present, they'll have painless jaundice. They may complain of like anorexia. They usually have like a 20-pound weight loss on diagnosis when we find these, which is why, since it's asymptomatic for so long, this is why it's typically like an advanced stage, and it's unfortunate because it doesn't create symptoms earlier, so we don't find it. But one of the classic findings we have with it is Cavassier's sign, and that's palpable non-tender gallbladder with jaundice. So that's going to be like your painless jaundice, but you have a palpable gallbladder, but they're not tender, so they don't have that Murphy sign or any pain when you're palpating it. So this is a sign that's associated with pancreatic cancer. So if you see jaundice, painless jaundice, and then that palpable non-tender gallbladder, you need to start thinking about some sort of pancreatic malignancy. And then we do like to get all of our labs like we do for all of these. So we'll get our liver function tests. We want to make sure we're looking at their bilirubin just to make sure that we don't have any sort of obstruction. And typically when we do find this with pancreatic cancer, it's like significantly elevated, so it's like 18 on average. So typically I've seen it higher than that on diagnosis, like in the 20s normally, I think is what I've normally seen this with. And then we want to evaluate if they have any sort of acute pancreatitis, so that's when we get the lipase with it as well. All right, so what do we do for these, or how do we diagnose them? CT scan is still our best test that we're gonna run. And it's the most, it's easily available, it's quick. And then if we have, if we don't find a mass there, then we may start looking at like ERCP to try to evaluate for any choledochal lithiasis, for, and basically what's causing that jaundice. And then ultrasound's not great unless there's some sort of biliary pathology like the stone associated with it, which typically it isn't. And what do we do for these? So surgical resection is really the only treatment that we really do surgery-wise for them. They might get chemotherapy depending on how advanced the disease is and if it's metastatic. And then, there are other palliating measures we can use like radiation therapy, but typically we do the pancreaticoduodenectomy, and that's the procedure of choice for this. If it's only in the head of the pancreas, so unfortunately it does have a high operative mortality rate. All right. It's going to be number one. That's what I told you guys a few slides ago. Basically, they failed their other procedures, and so this is typically our last resort, is the pancreatectomy. So we can have pancreatic neuroendocrine tumors. The most common one we see is an insulinoma. So this patient is typically going to have profound hypoglycemia. So a lot of times when we get all these patients, I don't know if they talked about it in EMED yet, but that's why we get a D-stick on them or a glucose stick on all these patients that present altered. So any of our altered patients, it's easy. We get a finger stick glucose right when they come in. And then we evaluate. So some of the times we will find a pretty significant hypoglycemia. That's one of the indications that they can have an insulinoma. Like it says, they'll have the bizarre behavior, and then they'll have that hyperadrenergic state. So they may have the palpitation, sweating, tremulousness, and then they'll usually tell you that they have these hypoglycemic episodes, and a lot of times you see some patients that are fasting, and it's improved with food. That's why when we get the D-stick immediately when they come in and we see this, we typically give them D50 or some sort of treatment if they're able to tolerate PO. We'll sometimes have to just drink a bunch of juice or something. And they typically rapidly improve their symptoms. It's also, the hypoglycemia can be can mimic a stroke as well. So a lot of times, that's why we check that glucose immediately. All right, so how do we diagnose this? So this is going to be your 72-hour monitored test, and we're just looking at their response to glucose. We're looking at their insulin level, C-peptides. We do an insulin to glucose ratio on them, and then we look at C-peptide as well. And then if we find this and we diagnose it, then we typically need to remove these promptly. So we have a few different ways we can do that, which is complete tumor extirpation versus we can do enucleation. And then some of it depends on where it's located at as well. So you may have to remove a portion of the pancreas, depending on whether it's in the tail versus the body or versus the head. And most of them do improve after we perform this procedure. It can recur, but not very commonly, only 3%. So that's pretty low. And then we talked a little bit about our Zollinger-Ellison syndrome, which is a gastronoma. But this is another one of the neuroendocrine tumors or pancreatic neuroendocrine tumors we can see. And the issue with this is, it does have a high rate of malignancy, especially if they have MEN1. So this is something we need to evaluate for. And the patient you're going to see this in is typically like your peptic ulcer disease patient who's had procedures on it, like whether, some sort of EGD or scope where it was embolized, and they start getting recurrent ulcers. So this will typically be a recurrent ulcer patient, you've treated them, and it hasn't improved, so you start thinking, what's going on with them? And that's when we start thinking Zollinger-Ellison syndrome. But most of them are located in the gastronoma triangle. And the presentation is going to be similar to your your peptic ulcer disease patients. So they'll have usually some abdominal pain and might have bleeding, diarrhea. And how do we diagnose it? So the fasting serum gastrin is diagnostic if it's over 1,000. It's normally not over 1,000. It's typically in the 400 to 500 range, which is still abnormal. So that's why a lot of times you'll see a patient that has, equivocal gastrin testing, and you'll have to do the secretive provocative test on these patients. And then if we diagnose somebody with MEN1, then we typically screen them for this. And it's usually associated with parathyroid tumors as well, which we'll talk about in the next block. But the primary approach is surgical resection for these patients. And obviously, the prognosis depends on how big the tumor is, whether there's metastases like with all cancer, and then whether they have MEN1 or not. If they have liver metastases, it's usually a poor prognosis for these patients. It's advanced. All right, moving on to the spleen. So historically, we actually used to just take everybody's spleen out if we had any issues. And it wasn't until the 70s they realized I think the spleen actually does something. Maybe we shouldn't remove it in everybody. So in the 80s and 90s, we actually started doing we stopped doing splenectomies on everybody with any sort of trauma. We used to remove this spleen, any sort of splenomegaly or hypersplenism, we removed it, and then we started to realize that it was actually causing more harm than good. So we started doing spleen sparing procedures, which we'll talk about. But we always want to look at the splenic size. It's highly vascular. So, and obviously it has a very huge importance on our blood. So it basically filters all of our blood. So when we remove it, we create tons of problems. It also helps us create red blood cells. So if we have any damage to it or we take it out, we start to see reticulocytes, and we can see our spleen, basically our bone marrow is trying to make up for our spleen function. And typically we see this most commonly in subabdominal trauma, where we have some sort of splenic abnormality. You'll see it a lot of times asymptomatically with a lot of different viruses like Epstein-Barr virus. So you will see these patients in your clinic in an outpatient setting, especially after typically some sort of URI type symptoms or a mono, and you'll get a pretty significant splenomegaly. And typically we just monitor these patients. We try to have them avoid trauma, so you'll typically write them profiles. All right. So there is a difference between splenomegaly and hypersplenism. So typically the hypersplenism is going to have some sort of underlying, whether they have sickle cell disease or some sort of other condition, whereas the splenomegaly is going to be secondary to something else, like your Epstein-Barr virus is probably the most common one we see with it. But one of them causes an enlarged spleen, the other one just causes an increase in your spleen's ability to take care of all your blood. So if we have any issues here, we can have sequestration and destruction, and you'll typically see a pancytopenia on your lab testing. So that is it's always important to get labs on anybody that you suspect splenomegaly. Typically, I find splenomegaly incidentally on a CT scan a lot of times for patients. And then here, most common reason for splenectomy now is typically medical indications. It used to be trauma, but like I said, we don't do it we try to save the spleen as much as we can. You will see like ITP quite frequently as well from hypersplenism, and that's going to be like you have like significant thrombocytopenia, typically below 30,000, sometimes below 50,000, with some sort of bleeding risk. But you will see these patients on basic labs that you draw, and it'll kind of make you go back to the drawing board or up to date and try to think a little bit more about what's causing this. But typically when we find that, like ITP, we typically start them on some sort of steroid if they're if it's below 30,000, or the patients are below 30,000, or if they have an increased bleeding risk. No, you don't need to know all of these indications for a splenectomy, but it is something just to understand. And then traumas. So a lot of times for blunt abdominal trauma, we do our fast scans. That's why we do that left upper quadrant fast scan. And we're just looking for any sort of bleeding from the spleen or any sort of laceration or rupture, which is very common. And they might have a peritonitis with it. They'll typically be unstable. So that's going to be an indication where we're going to open them up and do an exploratory laparotomy. We're still not, hopefully we're not going to have to remove the whole spleen. Most of the time there are procedures we'll talk about that we can do to help improve that without having to take it out. But most are treated non-operatively. And then here's some imaging findings. Like you can see the blood in the pelvis there in the middle one. So CT is what, obviously going to be our best test, and you're just looking for any sort of fluid where it's not supposed to be, any sort of abnormal hemorrhage, splenomegaly. You can also evaluate for like splenic infarcts. You'll see that a lot on CT scans as well when you're looking for this. All right. What do you guys think? 4? Yeah. So yeah, obviously free air below the diaphragm. Likely something else is ruptured, like you have some sort of hollow organ injury and you have some air that's leaked out. So that's gonna make you less suspicious for this. All right, and there's the, we're not gonna get too in depth on the procedure. You don't need to know these, exactly how we're going to do this surgery, but this just gives you an idea of how it's performed and what we do for it. We prefer for it to be in the elective setting because then we can use a laparoscopic technique. Typically the open splenectomy is used more for the trauma patient, and that's going to be your exploratory laparotomy that they're evaluating it for. But, if you do have to do an open, you are going to have a lot more bleeding, longer length of stay, and higher morbidity. All right, so what we need to do is, once we get that trauma patient, so are they stable or unstable, we're typically going to resuscitate them, and we're going to do our initial fast scan, looking for any sort of free fluid in the belly. It doesn't tell us where it's coming from, unfortunately, but the spleen is commonly injured with abdominal trauma, so it is something we have to consider. And then they might require blood, so if they respond to resuscitation and blood, then a lot of times we won't have to remove the spleen. We can do procedures like the splenography, and that's basically just like you would use any sort of hemostatic dressing on any sort of external bleeding that you see. It's kind of similar. They can use mesh wraps, they can use hemostatic dressings on the spleen, and that's so we can spare the spleen and we don't have to remove it. One of the things we need to consider though is abscesses can happen after this, so definitely from trauma we can get some sort of fluid in there and it becomes infected. So that patient will typically require a total splenectomy plus antibiotics. All right. And yeah, we just talked about it. So this is going to be your splenectomy patient if you have an abscess. All right. Post-op complications. So one of the concerns we have is since we're taking the spleen out, we get concerned about bacterial infection afterwards. So we do want to cover them for that encapsulated bacteria. You know, this is rare because we do treat for, you know, we do prophylactically treat a lot more now, especially in the more elective setting when we're doing the splenectomy. So we typically like to give them vaccinations prior to, like 2 weeks prior if we can. And, you know, if we can't, sometimes do it 2 weeks after. Then they might get it 3 months later as well. So it is a consideration. If we do find this requires antibiotics immediately. It's not something, because sometimes we wait for culture data. I don't know if they talk about that in other classes. If we're giving them antibiotics, we might not, you know, the theory is we might have negative cultures, and we do usually have negative cultures once we start the antibiotics. But for this patient, we don't want to wait. So a lot of times to get culture data so we can treat the appropriate bug with the right drug, we like to get those first, but in this patient, we don't. We want to immediately start antibiotics. So if you're treating a patient that just, you know, that had a splenectomy, this is something you need to consider. And then, you know, after the spleen's removed, you're typically gonna have a thrombocytosis. So, you know, it says 19% will have extreme. Most of them will have some sort of elevation of their platelets, but these are gonna be the cases where you see the extreme ones, which I've seen them, I don't know, in the millions, many times after you treat these patients. And what we worry about, you know, is some sort of venous thromboembolism, so they could have a higher risk of DVT or PE. However, just because they have elevated platelets doesn't mean we're going to give them anticoagulants like our, you know, apixaban or any of those other ones we typically give folks. But for these patients, this is going to be like your splenectomy patient. You do want to start them on some sort of aspirin or antiplatelet agent after they're treated to help prevent that risk of VTE. So we always need to consider that in these patients. All right. What questions you guys have?
With the splenography procedure, like what is that accomplishing? Is it just compression over the spleen?
Pretty much, you're just basically stopping the bleeding. Sometimes it'll be just some sort of hemostatic agent or a patch on there, or they can put mesh around it as well. But yeah, you're basically containing the bleeding in there. It's like applying direct pressure to anything else. What other questions? All right, you guys take a 10-minute break and we'll start the next one.